says all these breeds right here have the congenital, and these have congenital inherited, and these have congenital paralysis polyneuropathy. They don't have listed here as Labrador Retriever. I can tell you that every time I've seen laryngeal paralysis, it's been in a Labrador Retriever. Okay? So I'm giving you what Fossum says, but I'm telling you, if you see it, it's probably going to be in a Labrador. All right? It's more common in large breed dogs than it is small breed dogs. Males greater than females by 2 to 4 times. Okay? There you go, Labrador Retriever, then Golden Retriever. And like I say, I've never seen it in anything but a lab. All right? Uncommon in the cat. When it does occur in the cat, usually it's left-sided and can cause significant signs if unilateral. It's usually associated with either trauma or neoplasia or some sort of iatrogenic damage. Iatrogenic means we caused it, okay? These animals have a progressive history of respiratory stridor, mainly inspiratory. They may have a voice change and exercise intolerance. And then all the rest follows. Cyanosis, coughing, gagging, vomiting, restlessness, anxiety. They may be asymptomatic at rest. It gets worse with obesity, exercise, stress, hot environments, humid environments. About 1/3 of them will also have tracheal collapse, and some of them will have aspiration pneumonia. Oh, come on, computer. Oh, go away. Physical, it's not specific, but mainly associated with respiratory signs, okay? Labored breathing, inspiratory stridor. They can get hot because they can't cool off as well, because panting is a major way that dogs cool off. They may have muscle weakness, wasting, and weakness. They may have GI and metabolic abnormalities. You need to take cervical and thoracic radiographs to evaluate them. Sometimes ultrasound happens, ultrasound is helpful. You may want to do an esophagram to see if they've got megaesophagus associated with it. Okay, and then laryngoscopy. I showed you the video yesterday. That's how we usually diagnose it. Okay, just light dose of propofol and see if those arytenoids abduct in inspiration. If they don't, if they're just fluttering in the wind, you probably have laryngeal paralysis. Blood work's usually normal. You may want to check thyroid function, or may want to do a myasthenia gravis test, because sometimes that's associated with this condition. Okay. Some people have done nerve conduction studies. It's not very common anymore, though. You can do histopathology of affected muscles and nerves. Other specific tests for polyneuropathy or polymyopathy might be warranted. I don't know who really does all that. You usually diagnose them and say, okay, do you want to tie back or not? Your differentials, well, brachycephalic syndrome, there again, yes, the dogs that chase parked cars, okay? That's a big difference between them and Labrador, so I don't know how you could say brachycephalic syndrome is a differential, but there again, I'm repeating fossil. Laryngeal collapse, on the other hand, I can buy that. Tracheal collapse, yeah, I can buy that, but that's usually toy breeds, like Yorkies. Laryngeal masses, definitely, and trauma, definitely. This is really one of those diseases where the Labrador walks in and he's breathing like this. You go, LARPAR. Laryngeal paralysis, okay? So, I mean, yeah, okay, what are your differentials? You may have a mass, but it's LARPAR. You may have, trauma, but it's LARPAR. Until proven otherwise. Medical management, you're going to treat these guys like you're going to treat the brachycephalics and the laryngeal collapse dogs. Same thing, okay? You may want to use antibiotics because these guys are at risk of aspiration pneumonia and they may have already aspirated. And then surgery. Partial laryngectomy, arytenoid lateralization, that's the tie-back procedure. Castulated laryngeal fissure, I showed that to you yesterday. And then they describe a muscle nerve pedicle transposition where they actually bring in a new nerve and attach it to the muscle. That takes a couple of months for it to actually work. And then ventricular cordectomy. Most of the time, surgeons are doing the arytenoid lateralization, okay, tie back. Usually this is a ventral approach, so you put them in dorsal recumbency. Oh, by the way, a lot of y'all say ventral dorsal. It's ventral or dorsal, not ventral dorsal. One or the other. You can't be in both at the same time. If you can, I want to see it. If you're doing the arytenoidectomy or trimming the cartilages here, that's an oral approach. I don't know too many people that do that anymore. This is what most surgeons do, okay? Unilateral arytenoid lateralization, and you go in from the side on this. So they're in either right lateral or left lateral recumbency, and you approach it from this way. And you go back and you disconnect the cartilages here. There's an attachment, one to the other here. That's where they're showing the scissors cutting that attachment, cutting this attachment. Then you take your suture and run it through this cartilage and bring it back and run it through this cartilage. And that's not as easy done as said, because that cartilage is sometimes really friable and it wants to break and crumble when you run your suture through it, okay? Anesthesia, same as other respiratory conditions. It's very risky going under general anesthesia and coming out from general anesthesia. They're at high risk for anesthetic death. Intubation via tracheostomy is required for partial laryngectomy. That's where you go in through the mouth, but not the lateralization procedure. Okay. Just to remind you, again, this is the castellated laryngeal fissure procedure, where you make a straight cut down, go to the left, straight, right, straight, and then you take A and B and put them together. And it widens the opening. It's not working. Okay, post-operatively, you're going to monitor them really carefully for respiratory distress. They may gag or cough after surgery. They may have a little bit of swallowing discomfort. You want to give them soft food for the first 18 to 24 hours, and you want to exercise restrict these guys, minimize barking, and monitor for aspiration pneumonia. You're helping these guys, you're not fixing the problem. Okay, you're helping them move air more efficiently by opening opening their larynx, but they can't close it very well, so that's the problem with the aspiration pneumonia. These are the complications. The big thing is you've got to tell them that this is a progressive neurologic disease, okay? They can end up with megaesophagus. They can end up with diaphragmatic paralysis where their diaphragm's not moving. And people who nurse these dogs along long enough, they'll end up with a hind limb ataxia and eventually paresis and paralysis because it's progressive. So it's not a good disease to get. Prognosis, if they're mild to no clinical signs, they do well without surgery. Moderate to severe, Fossum says good with lateralization, 90% improved function. But I don't paint a bright picture for these folks, okay? Because this is not a cure, it's a Band-Aid. With partial arytenoidectomy, up to 50% develop fatal pneumonia or airway obstruction due to stenosis. And like I said, progressive neuropathy. All right. That's the end of that one. Now we can move on to trachea. So, trachea. This is to remind you of the anatomy. The trachea is supplied via blood vessels running on either side. And if you disrupt the blood supply here, you can end up causing damage to the trachea. So we got to be really careful when we're working around the trachea. The trachea itself is made up of C-shaped cartilage rings, and over the top is called the dorsal tracheal membrane. It does have a muscle associated with it, but it's a pretty wimpy muscle. Okay. Some of the things we do to tracheas, we can do a tracheostomy, whether temporary or permanent. You can do a resection and anastomosis. We treat tracheal collapse, and we sometimes see tumors in this area. So, remember yesterday I was telling you about the tracheostomy tube? It looks like an endotracheal tube, but it's curved and it's got this little thing here that you could tie around the neck. And it has, many of them have a second lumen in it, so you can take it out and clean it without taking the whole thing out. You either make a little slit in the cartilage rings and run this through, make a little window. Most folks do it this way, as in A, okay? Or you can do a window this way. But by and far, most people do it this way. These sutures we leave in there because when you're doing it temporarily, or you have to take it out and clean it, those sutures help you put it back in, okay? Help you keep it open and closed to take the tube out and clean it. This is what we use tracheostomies for, okay? Gain access, remove obstructions, collect specimens, facilitate airflow is probably the main one. And there's the names of the different ones. Y'all will get to do this in lab in the spring, okay? So remember these lectures. Save them somewhere. This is a permanent tracheostomy. I showed that to you yesterday as well. For treatments of mainly neoplasia of the larynx, or treatment of severe airway obstruction. It requires some care, very intense at the beginning, but it gets less and less as time goes on. The big thing is you got to tell these owners no more swimming. You got to be really careful when bathing, and it's probably better if you don't use a collar, better if you use a harness. Okay, their vocalization is diminished or absent. Remember I was like yesterday? That's how they bark, because they get very little air through their vocal cords. This is what it'll look like, okay? This is the endotracheal tube, if you're wondering. So temporary, you have to observe closely. There's tube cleaning. We're using sterile technique, gentle suctioning, nebulization, and sterile saline. You want to do a trial occlusion before you remove them. And that's if they're not large or cuffed, meaning the temporary tracheostomy. And you usually let these heal on their own. You don't close them. Okay. Permanent, not as much care is required. At the beginning, you inspect every 1 to 3 hours, clean as necessary. After 7 days, you decrease it to every 4 to 6 hours. After a month, usually once a day. You need to keep the hair clipped around that. You need to keep the animal in a clean environment because they can suck all kinds of stuff into their trachea. Okay? It's bad enough they suck it in when they're normal and suck it in through this hole that's right here on their neck. A lot easier. And then, like I said, a harness. Okay, resection and anastomosis. Usually you're talking about tumors. Sometimes it's stenosis or trauma. Sometimes they'll avulse, and you don't have to really remove anything, you just put it back together again. You close them primarily, second intention or resection and anastomosis. You can take, it says 20 to 50%. Okay, I can't imagine taking 50%. That's 8 to 10 rings. Split cartilage technique is preferred. That means you cut through the cartilage and then suture the two cartilages together. I imagine that's easier said than done. I've never had to do this, but cartilage is not easy to cut, I can tell you that. All right. If you have inaccurate anastomosis and tension, you're going to end up with stenosis. A lot of times these guys need a tracheostomy. Silicone tubes or grafts or prostheses have been used with veritable success. All right, tracheal collapse. You'll definitely see this. All right, Yorkshire Terriers, the poster child for it. Cartilage is flaccid and flattening. The causes are mostly genetic, but nutrition, allergens, neurologic, small airways disease, environment can make these worse. Usually they flatten in a dorsal ventral direction, so you see it right here on this radiograph. It's flattened right through the thoracic inlet. Okay. You have cervical trachea and thoracic inlet collapse or on inspiration. Okay. Intrathoracic trachea usually collapses on expiration. You might want to put a star next to this. Okay. So cervical on inspiration, intrathoracic on expiration. Y'all get my hint? Okay. Toy and miniature breeds, can you name a few? Like I say, Yorkshire Terrier is the poster child, but you can see it in poodles. Trying to think what else I've seen it in. Maybe Maltese. But by and far, you're talking Yorkshire Terriers. Males and females are affected equally. Okay. If you see it in a large breed, it's usually due to trauma. Okay, or masses or some sort of deformity. When you see this, it's usually older. They have it as puppies, but they don't notice. You don't notice it until they get to be about 6 to 8 years of age. I used to be able to elicit a cough by rubbing the neck on puppies, and I'd warn them, your dog's at risk of developing tracheal collapse. Keep them in a clean environment. Don't smoke around them. Don't smoke in the house. Keep them cool. Keep them calm. They'll have a history of respiratory noise, dyspnea, exercise intolerance. They will turn blue in a heartbeat. You get them in the clinic, you start messing with them, they'll get stressed, they'll turn blue on you. Okay? And they'll faint. As they get older, it gets worse. It's exacerbated with noxious stimuli, excitement, depression, infection, hot humid weather, eating and drinking. Like I said, these guys, you can just lightly rub their throat and elicit a cough on them. A lot of these guys have concurrent problems. A lot of them are fat, a lot of them have nasty teeth. They may have laryngeal paralysis that goes with it, or paresis. They have heart murmurs, that's usually because of their nasty teeth. Usually you're talking about mitral insufficiency. They may have large livers. Like I say, cough easily elicited with palpation of the trachea. And you want to listen to their lungs, see if they got any respiratory noises in their lungs. Test, here again, radiographic views of the trachea and thoracic trachea, or cervical and thoracic trachea are warranted, and you want to catch them at inspiration and expiration. Okay. Blood work's usually normal. We grade these things, all right? It's pretty simple. 25% constriction, 50, 75, and complete. And here are your pictures. Okay. Grade 1, you got a little bit of a sagging membrane. Grade 2, the C-shaped cartilage is starting to flatten out. Grade 3, it's really flat, and grade 4, it's like bent in the middle. And this is what it looks like in person. So this is probably grade 3 right here. See how flat that is? Here's your differentials. This is not a brachycephalic though. This guy right, that's not brachycephalic. So I don't quite buy that one, but the rest I can accept. Laryngeal paralysis is usually big dogs. But you gotta think of pulmonary disease, cardiac disease, hypertension, trachea, etc. Medical management, if they're mild, greater, less than 50% flattening, improvement will help, our medical management will help improve these guys. You want to get them on a diet if they're fat. You want to clean up their environment. You want to put them in a harness. Antitussives, antibiotics, bronchodilators, anti-inflammatory agents, sedatives. In the hospital, I don't know about at home, but in the hospital you can give them oxygen and mucolytics and nebulizers, okay? These guys will progress too, okay? So medical management will help them for a little while, but they will progress. Here's your poster child. So what can we do surgically? Well, we can stent that trachea. We can't replace it, but we can stent it. There's extraluminal stents and intraluminal stents. Extraluminal stents, we usually make them on our own. We make them out of syringe cases. They do have some commercial products. And then intraluminal stents are self-expanding, elastic, and this is what they look like right here. I think I can see that. Pretty good. This is the extraluminal. That's really hard to see. But basically you make a C-shaped plastic ring from the syringe casing, and then you suture it around the trachea to help pull it out and make it like it should be, a nice C-shape. Moderate to severe cases, i.e. 50% collapse or more, that are refractory to medical treatment probably should receive surgery. You got to pay attention to the concurrent problems, okay? The more problems they have, the poorer they're going to be for surgery. If the trachea collapse is the only thing they have, then you might